Okay. Good morning. As part of our coverage of the recent advance in surgery, because the recent advance surgery is a paper in theory examination, both in MS and DNB. So we are trying to cover all the topics of recent advance surgery. And as part of this, today, Professor Shibajyoti Ghosh is Professor of Surgery at Calcutta Medical will deliver a lecture on a recent advances in management of a patient having a incidentally dilated common bile duct. It's a very common entity in clinical practice. Dr. Ghosh, please start.
Good morning, everybody. Good morning, Professor Makhunlal Shah once again. So as Professor Shah started, that is a very common practice nowadays. So in taking cue from him, it is in fact in today's topic of discussion is very, very relevant to the present day clinical practice, as ultrasonography is widely used. As a matter of fact, nowadays ultrasonography in some other areas of surgery is used as a routine extension of clinical examination. So for that matter, for the evaluation of the abdominal symptoms, ultrasonography has become first line of imaging investigation modality nowadays. And as a result of that, we are seeing gradually more and more number of cases of asymptomatically dilated common bile duct. Now, the question is what to do with such kind of patients. Should we leave the patient, ignore the asymptomatically dilated common bile duct patient, or will start a battery of investigation to establish the cause of dilatation, which may or may not be cost effective, because here are some studies. So this is a Korean study which has recorded the from their database the number of cases which had asymptomatically dilated common bile duct in a long period of time, and they have ultimately come to the conclusion that only 30%, approximately 38 out of 514 patients, that means roughly comes to around 7 to 8% patients have the causative symptom, causative lesion. In another study, this is basically a systemic review of evaluation out of total 882 articles and 9 peer-reviewed articles. They have concluded that the 33% of the patients with asymptomatically dilated common bile duct in fact had some causative factors, and the common factors, common causes were like common bile duct stone, chronic pancreatitis, and periampullary diverticulum. So let's first see what's the definition of dilatation of common bile duct. Now, the definition of dilatation of common bile duct varies according to the treatment modality that you are investigating modality that you are seeing. So in ultrasonography, it is up to the 6 millimeter of the diameter of the common bile duct. Why it is 6 millimeter in ultrasonography? Because in ultrasonography, it measures the internal diameter, leaving behind the wall of the common bile duct. In some cases, the common bile duct wall may be thickened. So in ultrasonography, it is the internal diameter of the common bile duct that is measured, and that is approximately 6 millimeter. Up to 6 millimeter is considered as a normal. Whereas in ERCP, it is up to 8 millimeter, because in ERCP, a contrast is injected, and as a result of that, there is slight dilatation of the common bile duct. So that dilatation is taken into account, and it is in ERCP up to 8 millimeter is considered as within normal limit. Whereas during surgery, when we look into the common bile duct, we look at the outer diameter of the common bile duct. So it is traditionally said that up to 10 millimeter size of the common bile duct is considered as normal diameter of common bile duct. But how to measure 10 millimeter intraoperatively? So it is just approximation, eye approximation. We all know the diameter of a common wooden pencil that we use. The wooden pencil is, the outer diameter is 10 millimeters. So if anything larger than the diameter of the wooden pencil, so we do intraoperatively, we will consider that the common bile duct is dilated. Now, with this in mind, so today's importance of today's topic is that we need to evaluate the dilatation of the common bile duct in asymptomatic patient. Before that, we need to have a very sound knowledge of the common causes of biliary obstructions and common investigations that are used for the diagnosis of biliary obstruction. Now, before that, as we have discussed about the ultrasonography regarding the assessment of the diameter of the common bile duct, there are certain pitfalls in the radiological assessment of all these investigations. For example, for ultrasonography, the first thing is that the lower end of the common bile duct cannot be visualized well in ultrasonography, as all of us know from our undergraduate days, because of the overlying gas at the duodenum. So the gas is highly eco-reflective. So because of that, that cannot be assessed properly if there is any lesion at the lower end of the common bile duct. And this is very important. That is the CBD diameter must be measured at the porta, because that should be the standardized, because CBD diameter may vary at various levels, and also the height of the common bile duct at the porta should be taken as the standard rather than the transverse diameter. Why? Because at the porta level, the CBD is slightly oblique. Now, if you just consider that if you take a cross-section of a vertical tube, so the cross-sectional area will be less than if you take a cross-section of a same tube when it is lying obliquely. So the imaging of the common bile duct, which is in ultrasonography, is operator dependent. So that thing is very, very important. So to standardize this, diameter at the porta hepatis should be measured. And remember that again in porta, the common hepatic duct is slightly oblique, and it is slightly oblique. So at that level, the height should be measured rather than the width of the common bile duct. So that should be the standard practice while reporting the diameter of the common bile duct in ultrasonography. And also there are certain things we should also keep in mind, and in some cases we need to discuss with the radiologist, that sometimes when the cystic duct is incorporated, because of the low insertion of cystic duct into the common bile duct, into the CBD, and that the combined measurement of cystic duct and the common bile duct may be reflected as the dilated common bile duct. So these are the certain pitfalls of ultrasonography which should be kept in mind when we are looking at a patient who has come to us with an ultrasonography report of dilated common bile duct. And other than this, some stones, mimickers are like air bubble, blood clot, and so on. Now, coming to the causes of incidentally dilated bile duct, we should remember that there may be the physiological causes, and there may be some adynamic causes, and there may be some dynamic causes. So physiological causes, we can say that in elderly age group, particularly over the age of 85, the common bile duct tends to dilate a little bit. And also in post-cholecystectomy patient, particularly 2 years after the operation, there is supposed to have some dilatation of the common bile duct, because the storage function of the gallbladder is not there. So to compensate that storage function, bile duct, common bile duct may take up some of its burden, and it may get dilated. Chronic opioid use is another cause, although it is not so very common in our country. And of course, this is a very, very important clinical entity. Most of the time we overlook in our clinical practice, that is the sphincter of Oddi dysfunctions, and also bile duct dysfunctions, bile duct sphincter dysfunctions. So these are the two entities that we overlook most of the time in our practice when we get cases of asymptomatic dilated common bile duct. So here are the short list of causes of dilatation of the common bile duct. So these maybe if the anatomical location is hilar or the upper third, so hilar cholangiocarcinoma and carcinoma gallbladder. In our country, in this part of the country, carcinoma gallbladder is supposed to be the most common cause of malignant biliary obstruction at the portal level or mid-CVD level. In mid-CVD, carcinoma of the gallbladder, it is said that mid-CVD obstruction in elderly or patient or in patient of malignant jaundice, mid-CVD obstruction should be gallbladder carcinoma should be considered as the cause until proved otherwise. And rarely some metastasis or lymphoma may cause malignant obstruction, but mid-CVD levels, benign obstructions are more common, like Stone's, Mirigy syndrome, postoperative benign biliary stricture, primary sclerosing cholangitis, and portal cavernomatous dilatation, maybe in the form of portal biliopathy, cholangiopathy, hemophilia, and parasites. These are the common cause of mid-CVD obstruction. And in distal CVD obstruction, most of the causes are malignant. So periampullary carcinoma, pancreatic carcinoma, and rarely IPMN, intracranial papillary mucinous neoplasm. Or in the benign group, chronic pancreatitis. That is also very important because in our country, chronic pancreatitis is a very common entity in certain parts of India. So that may compress the lower part. The fibrosis due to chronic pancreatitis may compress the lower part of the common bile duct and producing dilated common bile duct. Choledochal cyst and pancreatic pseudocyst are the two other entities. Now, the American College of Gastroenterologists, they have proposed some of the risk factors for choledocholithiasis, because choledocholithiasis is supposed to be one of the commonest cause of common bile obstruction. So these are the various categories. The high risk categories are, of course, when we see a stone in the CVD stone in the on ultrasonography, or there are features of acute cholangitis, or the patient has a serum bilirubin more than 4 milligram percent. Remember, if the bilirubin, there is standard saying that serum bilirubin more than 10 is more common in malignant obstruction than the benign obstruction. So this, when you see a patient having bilirubin more than 10, so think about the possibility of malignant obstruction. And intermediate risk group as dilated common bile duct on ultrasonography, serum bilirubin between 1.8 to 4 milligram percent, or liver enzymes elevated, or clinical gallstone pancreatitis. So these are the high risk group for choledocholithiasis. So we should keep in mind when we see patients in the OPD with these features. Now, what to do if you see a patient with dilated common bile duct, or you can say the asymptomatically dilated common bile duct. Now, first thing that we'll have to, from clinical history and examination, we'll have to assess whether this is a benign biliary obstruction or it's a malignant biliary obstruction. Now, for the benign group, the imaging that we can advise after ultrasonography should be the MRI or MRCP, MRI with MRCP. So that will give us the morphological detail of the common bile duct and also the level and nature of obstruction. But in case of malignant obstruction, so that information is not enough, or maybe the surgeons are not so oriented with the MRI interpretation of the MRI. So in such cases, the CT scan, particularly the MDCT, will be more helpful because it not only gives us information about the nature and the level of obstruction, but we can also assess the operability in malignant obstruction, and also we see certain things like whether there is liver metastasis present or not, lymph node status, lymph node metastasis, presence of ascites. And for if in operable cases, it is very, very important to look for any abnormal anomalies, abnormal vascular anomalies. So that has to be ascertained beforehand. Otherwise, when there are certain anomalies, particularly the replaced right hepatic artery arising from superior mesenteric artery, so there is a chance of catastrophic bleeding unless and until they are very aware of this at the time when we transect the common bile duct. And the role of ultrasonography is also very important, particularly in indeterminate type of groups where we are not very sure about the nature of obstruction, whether it is benign or whether it is malignant, particularly in the lower end of the common bile duct, whether we are not very sure if it is a stone disease or it is a very early case of periampullary carcinoma, or it is inflammatory head mass in the pancreatic region. So ultrasonography not only give us these informations, but we also can take the help of endoscopic ultrasonography for tissue sampling and to arrive at a diagnosis. Now, if choledocholitis is suspected, it is associated with 10 to 20% of gallstone, and of course, investigation of choice would be MRCP. So this is a very common practice, and we are doing it. I mean, everybody is doing it regularly. So if I go to my second slide, where we had shown you one USG report of ultrasonography, which says the dilated report says it's a case of follow-up case of carcinoma of the ovary, and on follow-up ultrasonography of the abdomen, it showed nothing other than the dilated common bile duct. Now this is the MRCP of the same patient, and as you can see that there is dilatation of the common bile duct, but there is no intraluminal pathology can be seen. And this patient was an elderly patient around 60 plus age group. So maybe this could be a case due to the post-cholecystectomy status, because patient had already done cholecystectomy 15 years back. So this is possibly in the group in which dilatation of common bile duct is due to post-cholecystectomy of the patient. Now, ultrasonography is also, EUS particularly, is useful. There are some pictures of endoscopic ultrasonography, and it can very well see if there is any stone or if there is chronic pancreatitis. And also, as I said, it can also demonstrate the presence of a lesion, mass lesion, particularly in the periampullary region. So endoscopic ultrasonography is very, very useful. And as you know, the endoscopic ultrasonography is used nowadays not only for this purpose, for the diagnosis and tissue sampling, but nowadays it is also used for biliary drainage, endoscopic biliary drainage. And because it is nowadays possible to pass a catheter above the lesion, and it can be used for endoscopic biliary drainage. So these are some latest use of endoscopic ultrasonography, therapeutic use of endoscopic ultrasonography. Now, if you look into the various advantages and disadvantages of MRCP and the US, and we can see that both are non-invasive and comparable in terms of sensitivity in the diagnosis of choledocholitis. But certain things I would like to mention here, that the pitfalls of MRCP, because MRCP can falsely detect stone due to flow artifact or flow void. There are two terms we should remember regarding the MRCP. One is flow void and another is Persian volume effect. Now, what is flow void and what is Persian volume effect? Now, flow void is when any fluid that passes through a luminal structure very quickly, and MRCP cannot detect that, and that can be represented as void. So that means there will be no signal from that area, and that may falsely interpreted as there is presence of stone. So this can happen particularly at the junction of the common bile duct with the cystic duct, because in the cystic duct common bile duct junction, there might be sometimes turbulence flow, which may falsely give signal void, and that may be picked up as stone. So we should be very aware of it, and we need to discuss this thing with the radiologist. And MRI may also miss stone due to partial volume effect. In order to diagnose stone, gallstone, or any lesion in MRI in common bile duct, there must be a difference in the tissue concentration between the two structures. Otherwise, the MRI, the whole sequence will look same. Which I mean to say, if the stones are packed within the common bile duct, so there will be no tissue fluid between the two stones. And as a result of that, in MRI, this picture will look like as if there is the same consistency or same tissue density throughout the lumen. So in that situation, the stones may be missed, or there will be no interluminal stones. So this is another pitfall of MRI. So it has happened that in our practice also, in my practice also, I've seen patients which are diagnosed as periampullary carcinoma, dilatation of the common bile duct, and by repeated USG and MRI, which has not been able to detect any lesion within the common bile duct. And when we opened the patient and we found that the common bile duct is packed with stone. So reason for this, that there was no space. It was so tight within the common bile duct. There was no space between the two stones of so as to any fluid remaining between the two stones. So the MRI has missed is because it has interpreted that is a homogeneous consistency within the common bile duct, and they have missed it as a representation of the stones. Sensitivity for stone is less than 6 millimeter in US, and biopsy can also be taken from endoscopic ultrasonography. So these are some pictures of endoscopic ultrasonography, the ERCP. So this is normal ERCP, and we can see here the presence of stone or filling defect in the ERCP. So these are presence of stone. However, this one thing you must remember that.
Excuse me, sir. Sir, yeah. Can you increase the size of picture? Sir, your picture size is big and original picture size is small, sir.
Okay. So this ERCP, remember one. Yes, please.
Sir, I just wanted to ask, sir, you said that when stones are just packed and there is no space for fluid bile to flow, it sometimes mistakes it, means it does not detect, MRCP does not detect the stone. So is it that the common bile duct is, means stones are so enlarged that so as to occupy the whole space of the common bile duct?
Yeah, it happens. Once in a lifetime, you will see that the whole of the common bile does it turn into rather a stone wall of stones. There is no space. There is no fluid. Okay. In fact, you can also find no bile when you open the common bile and remove the stones. There is no bile. It's only the stones over there. So, so this is a possibility.
Okay.
So regarding ERCP, one thing you must remember that the standard dictum regarding ERCP is that it should be used for therapeutic intention, not for diagnostic intention, because of the life-threatening complications of ERCP-induced pancreatitis, so which can be avoided. So and for ERCP we have other options like MRCP. So unless and until we plan for doing something interventional or therapeutic, unless and until we plan for some therapeutic procedures like either putting stent or taking biopsy or bile culture. So if these are drainage, so if these are indicated, then maybe ERCP will be helpful along with therapeutic procedures. We can do the diagnostic, can use ERCP as a diagnostic tool. Otherwise, purely for diagnostic purpose, it should not be used, because there is even the 5% chance of life-threatening ERCP-induced pancreatitis. Now, in CT scan, particularly in MD-CT, if we format triplanar reformatting, if you do the coronal sections, so from there we can also delineate the common bile duct and the structural changes and the structures outside the common bile duct. So relations with the structures outside the common bile duct, that can also be very nicely assessed on CT cholangiogram. So this is another modality, and when we are using MD-CT for the evaluation of a patient with malignant bile duct obstruction, so CT cholangiogram is another option that we can draw from the MD-CT. And regarding intraoperative cholangiography, yes, we have the options for having intraoperative cholangiography, and it had certain disadvantages, like it is highly operator dependent, may not be suitable in acutely inflamed gallbladder or short cystic duct, and detection of asymptomatic CVD stone may lead to unnecessary CVD exploration or open conversion and very high rate of false positivity. So, but it's still a matter of debate whether you should use intraoperative cholangiography routinely for cholecystectomy, particularly laparoscopic cholecystectomy, and it is still not recommended. So these are the few pictures of intraoperative cholangiography. You can see here there are some filling defect here. So there are stone in the common bile duct detected during intraoperative cholangiography. Intraoperative ultrasonography is another modality that can be very, very useful at certain times. However, it is sometimes it is very difficult. It can be done from third port or epigastric port. It helps to differentiate between biliary sludge from polyp and other intraluminal pathology, and also in local extent, and sensitivity and specificity around more than 90%. And needs learning curve for the surgeon. So intraoperative ultrasonography, this has been about the laparoscopic intraoperative ultrasonography. Even this intraoperative ultrasonography can be used in open cases also, but it is very cumbersome, and it's not possible for the surgeons unless until we are trained in doing this intraoperative ultrasonography. We need to have the radiologists to be present in the operation theater, and the probes that they have usually used is a quite large probes, and that cannot fit into the areas in the gallbladder region or common bile duct region. Even in the porta hepatis, the ports cannot fit properly. I mean, the probes cannot fit properly, and really not very useful. I have used quite a few times, but I'm not very satisfied with that. Now, if periampullary pancreatic pathology is suspected, so obviously triphasic MD-CT would be the treat with the investigation of choice. And even if you have some doubts regarding the pathology, so EUS and plus minus fine needle biopsy from any suspected lesions can be helpful. Tumor marker CA99. Remember, in patients of jaundice, the interpretation of CA99 should be very, very careful, because in jaundice, biliary epithelium is already inflamed. So the CA99 level will be even will be increased in benign pathology also, where there is obstructive jaundice. But however, the CA99 level more than 100 is more in favor of malignancy, and more than 500 maybe may denote that metastatic disease. Polyductal cyst. Okay, so diagnosis of polyductal cyst is most of the time we make from MRCP pictures. And one interesting type of polyductal cyst is formifrostic anatomy. That means where the polyductal cyst is present, but there is no biliary dilatation seen in patient with typical features of obstructive jaundice and recurrent pancreatitis. However, if you look into the cholangiogram very carefully, we can see that the long common channel, which is one of the hallmark of the diagnosis of choledochal cyst, should be more than 1 centimeter. So if these features are there, even if case of asymptomatically dilated common bile duct, if you see the long common channel, so we should be very cautious about the diagnosis of possible diagnosis of choledochal cyst, particularly in young patients. So this patient may need follow-up and to treat accordingly. So in summary, we can say that if the pathology is common bile duct stone, so investigation of choice would be MRCP. If periampullary lesions is there, so it should be the triphasic MDCT. If it is pancreatic parenchymal lesion, again, same investigation, because in triphasic MDCT, the morphology of the pancreas and the pancreatic duct is well delineated. And along with that, we can also see the surrounding, the condition of the surrounding structures, any other pathology, associated pathology, and most important, the vascular anatomy. And in biliary stricture, if this biliary stricture may be malignant or maybe benign biliary stricture, so MRCP will give us a better informations. And this sphincter overflow dysfunction, remember that this is a clinical entity which is most often neglected in our practice, and particularly in asymptomatically dilated common bile duct, we should give it a thought about the sphincter of ovary dysfunctions. So regarding the sphincter of ovary dysfunctions and biliary duct sphincter dysfunctions, you should read about this Rome criteria. These are the gold standards. And on sphincter of ovary dysfunction, Milwaukee's criteria and types we should remember. And sometimes maybe we'll be able to diagnose this. Of course, we need to have manometry, which is not present in every institutions. So this is another area of sphincter dysfunction which we should keep in mind. We should be very familiar with this in order to diagnose, because if it is a sphincter of dysfunction, particularly Milwaukee type 1, and then sphincterotomy is gives a very good relief for the patient. And if it is biliary dyskinesia, cholecystectomy will give the patient good relief. So we need to consider this as a probable diagnosis, a possible diagnosis in case of asymptomatic or mildly symptomatically dilated common bile duct in such cases. And if there is periampullary diverticulum, of course, we can do duodenoscopy. So there are a few words about the recent advances in the biliary tract imaging. But number one is intraductal cholangioscopy, because these are the endoscope which are very small fibers endoscope basically. So with this, we can get into the common bile duct, we can get into the main pancreatic duct, and like any other luminal structures, any other luminal structures we can take, we can see what is their pathology, we can take biopsies, and sometimes we can do some therapeutic procedures like stenting also. And so from this, we the spyglass mother-daughter system. So spyglass investigations technology is the latest one, which is used for particularly the common bile duct and also in case of pancreatic duct. So there are two scopes used, that is mother and daughter. The daughter scope is inserted through the side channels of the mother duodenoscope, and daughter scope has also a working channel permitting passage of microfibers, microforceps, and intraductal lithotropy fibers, and suction irrigations and all this. So these are all technical aspects. And but remember the spyglass cholangioscope, which is can be used nowadays, and some institutions of repute like Asian Institute of Gastroenterology, they are, I think, doing it routinely, and maybe some other institutions which are also there using this spyglass cholangioscopy routinely. So these are some pictures of spyglass cholangioscopy. So we can read more about this from the recent advance the latest recent advance book of recent advance by Roshanal Gupta, maybe probably the edition 17. From there, you can have very good information regarding endoscopic use of endoscopy in hepatobiliary region. So this is one picture for taking polypectomy by spyglass cholangioscopy. And this intraductal ultrasonography is also is done nowadays. So this fiber, the probe size is just about 2 millimeters, and the high frequency ultrasonography 12 to 30 megahertz provides the improved resolution, 3 systems. So these are all technical issues and can accurately determine the local invasions and can accurately differentiate between benign and malignant lesions. So intraductal ultrasonography is another investigative modality which is used in certain institutions. And this one, we are hearing about this investigation for almost for last 5 to 10 years, but however, I don't think this is very much popular. So this confocal laser endomicroscopy is a very small biopsy probe, only 0.9 millimeter, and permits histology at cellular and subcellular level. Sensitivity is around 83 to 98%. And the hallmark of neoplasia on confocal laser endomicroscopy is that the presence of glands or villi within the biliary ductal epithelium with increased vascularity. So laser endomicroscopy means you are introducing an endoscope within the luminal structures and you get enlarged pictures, and so much enlarged that you reach the cellular level and you reach the subcellular level, and by means of using sometimes some contrast or dye, we can see in fact the cells through the endoscope, and from there we can have the diagnosis. However, this presence of vascularity and presence of changes in terms of glands and villi within the biliary epithelium that are more features of neoplasia in case of confocal laser endomicroscopy. Tissue diagnosis required only when the cholangiography pictures are non-confirmatory, and it can be taken by ERCP or EUS guided. Now, these are the few things about the advances in tissue samplings, not only the routine histopathological examination and the other things that we are using nowadays, this mutational analysis of P53 KRAS mutations, telomerase RNA estimations, or DNA proliferations by means of digital image analysis of FISH techniques. So these are the newer varieties of histopathological examination which can give a better diagnosis in case of doubtful lesions. So these are in short about the various treatment modalities of according to the pathology, and I think most of you know about this. So these are things we should also keep in mind. So in conclusion, we can say that although asymptomatic isolated common bile duct dilatation may be associated with risk of malignancy, especially in elderly age group, association of obstetric jaundice. So basically, few things we'll have to consider here, that when you look into a patient coming to the OPD with say with the ultrasonography report of dilated common bile duct. So next thing, according to the history and clinical presentation, so whether we'll have to decide whether we'll go for further investigation or not. So if any further investigation is required, we'll have to decide whether we're dealing with a very early case of a malignant obstruction or malignant disease or benign disease. So we can ask for next investigation after ultrasonography, probably could be MRCP. But here we'll have to again evaluate the dilatation of the common bile duct. In the in the articles that we mentioned at the onset, at the beginning of our lecture, it is written that we'll have to evaluate the dilatation on MRCP, whether it is a dilatation of the common bile duct only, or it is a dilatation associated with the intrahepatic biliary radicals. IHBR dilatation also is there or not. If both CBD and IHBR dilatation is there, that is more likely to be pathological or may have a causative lesion rather than only dilated common bile duct. So this thing we'll have to keep in mind, and so accordingly we'll have to modify which investigation would be better. And second point I like to mention here that in case of asymptomatic dilated common bile duct, if the patient has otherwise no other concerning features, so it is best to reassure the patient and follow up the patient. And in the follow-up period, if it is found that the dilatation is stable, that is not increasing, so we can keep the patient for further follow-up. But if the dilatation is increasing, then we need to start the investigation. So two things are important when you see a patient with asymptomatically dilated common bile duct. One thing is we'll have to see whether the dilatation is uniform in a sense that whether both the common bile duct and IHB are dilated or not. If both things are dilated, so their chance of detecting a pathology is more rather than only isolated dilated of common bile duct. And second thing, in case of isolated dilated common bile duct, if it is stable dilatation in the follow-up period, so the patient can be follow up and reassured that further investigation is not needed. So this is all from my side for today's discussion. Thank you very much.
Thank you very much, Dr. Ghosh, for the
Sir,
nice
can we-
presentation. Yes, Ishita, just a minute.
Sir, can you
So-
just go to the previous slide, sir, before the conclusion? Sir, here chronic pancreatitis causing extensive compression over CBD. What is the treatment? What's the full form of DPPHR?
Oh, that is duodenum preserving pancreatic.
Okay.
Biggest operation.
Okay. Oh yes. Okay. Thank you, sir.
Or it can be a simple phrase sometimes can cause relief of this compression, and if need be, you can add a hepatic jejunostomy along with the chronic pancreatitis procedure. So there are a number of options.
Okay. Thank you, sir.
Dr. Ghosh, you've given a very good description about all the entities, but one thing I like to emphasize is in colorectal cyst, in different type, particular type 1, it's only the extrahepatic duct which is dilated, not the intrahepatic biliary radicals. So one has to keep in mind that sometimes only the extrahepatic biliary dilatation can also be a pathological entity.
Yes, very much so.
So any other question from any of the participants? So this is a very good description of the whole entity, because in exam you might have just a short note of incidental bile duct. One should define, give a definition, give the normal situations, and then the pathological entities, and what should the further investigation, and based on that, the outline of treatment.
Absolutely.
If there is no question, we should conclude. Thank you, Dr. Ghosh, for the nice presentation.
Thank you, everybody, for attending the class. Thanks a lot.